really thank you for the invitation. It's really an amazing meeting, and I learned a lot working with Fabrizio for the last 5 years, and I continue to learn a lot, so thank you very much. So what I can tell you about refractory cell disease in adults. So just for you to point out a few things, the clinic is pretty much the same as in children. The prevalence of the disease is lower, actually, probably 10 times lower than what you see in children. And in terms of characteristics of the disease, there is no gender predominance. In some series, there is more females than men, but it's really not very consistent. There is no familial aggregation, and there is no clear comorbid association. Although we produced a paper where, for people with chronic arthritis, we had the feeling that some of these patients were able to be classified or identified as spondyloarthropathy. So when we discussed this morning with GI symptoms, I have patients with cell disease plus ulcerative colitis. So I don't know in what extent there is not a kind of an overlap between cell disease and spondyloarthropathy spectrum. So what is refractory adult cell disease? I'm not completely clear. And you say refractory, some people will use difficult to treat, so D2T disease. And actually, because things are too simplistic, so we have to complexify the thing. During the next ACR meeting in a few days, there will be the D2M spondyloarthropathy, the difficult to manage. So I think behind that it's exactly the same, but it's not a very unique picture. For some patients, it's just a question of drug dependency. So you are not able to taper the treatment, although the treatment are approximately efficient enough. It can be the case for prednisone, but also for biologic DMARD. There is a question of life-threatening conditions or complications. So clearly, it's for macrophage activation syndrome. We may have that in adult patients, but it's less frequent than in children. Lung disease, it was not described for a long period of time, but now we have a few patient. I have a patient with just clubbing, and up to now she doesn't have any lung involvement, but I continue to follow up the patient to be sure that nothing will appear. We have much more problem with liver problems, and especially fulminant hepatitis in some patients, and it is always a very complex situation because drugs are potentially involved, and you have some hepatologists who are likely to say, stop the treatment, this is the reason for the elevation of liver function test. And actually the only patient who died in my own patient had a fulminant hepatitis, and despite the liver transplantation, we are not able to control the disease. And finally, I will just at the end point out the non-inflammatory residual symptoms. It has been described in rheumatoid arthritis, you know, in refractory rheumatoid arthritis or difficult to treat rheumatoid arthritis. We separate out persistent inflammatory rheumatoid arthritis, PIRA, and NIRA, non-inflammatory refractory rheumatoid arthritis. And this may happen also in cell disease. So this is how we organize our thinking. It's probably too simplistic, but it's a way for us to understand what is going on and how we will organize the treatment. So we need to stratify what is the refractory disease. And in terms of clinical expression, we said this morning standard cell disease or classical cell disease, where you have all the features of cell disease, but some patients in the middle are really very active, and this patient may have important pericarditis or tamponade, or some of them may also have myocarditis. For this patient, when we do the dosage of IL-18, we have high level, around the 10,000, let's say. And some of these patients are likely to have partial response to IL-1 or IL-6 blocker. So here's a question, and we'll discuss that in a few minutes. Do we have to increase the dose, or rather to change the treatment? And it's not clear in our mind. And at the right part of the slide, you have really what you call as pediatrician hyperinflammatory syndrome. Is not as popular in the adult world, but actually more and more we try to convey this message that people with very high ferritin levels, this hyperferritinemic syndrome, correspond to the notion of hyperinflammation, to involvement of innate and adaptive immunity, with very, very high level of IL-18, and also in this patient increase of CXCL9, reflecting the involvement of interferon gamma. So here, of course, we have patients with mass, we have a few patients with lung involvement, we have patients with liver failure, we have patients with pulmonary hypertension, and so these patients are really very challenging. In terms of involved pathway, so we discussed that, and you see that where there is a clear difference is for the right part of the slide, where we found an excess of patients with HLA-DR beta 115. We have the role of interferon gamma and potentially of CD8 positive population, but we have some evidence for the HLA and interferon gamma in adults. For the role of the CD8 population, for example, up to now it's not so clear in adults. And in terms of treatment, it's quite simple for the left part of the slide with IL-1 and IL-6 blocker, and in the European guidelines, we really recommended to use very early IL-1 or IL-6 blocker, and potentially to completely avoid glucocorticoids, although we are not able to identify the patient for which we can completely avoid them. In the middle, we have this patient with very intense inflammation, but we have the feeling that still the main pathway is IL-1. And here there is the question of optimizing the dose of anakinra, especially in children. You're likely to use IV infusion, to use huge amount of anakinra. In adults, we have sub-Q, we are not used to IV, and it's 100 milligram or eventually 200, but it's not very easy to do that for a long period of time for the patient. So let's say it's between 1 and at the maximum 3 milligram per kilogram and per day. So it's really limited dosage. For this patient, the bispecific antibody, anti-IL-1, anti-IL-18 would be probably a good option. And for the patient with hyperinflammatory syndrome, this is where we still can discuss the optimization of IL-1 dose, but we would be very happy to use MAS 825 or to do emapalumab, and we did that for some patients, and actually we were quite satisfied with this option. Our experience in terms of, I can provide you the slide, Fabrizio, no worries. And for immunosuppressant, we are not clear at all. We discussed this option in the recommendation, but the experience is really limited with these agents. An important message, and we will come back to what we were discussing yesterday, what we recommended in the EULAR press recommendation, is that to make the diagnosis of macrophage activation syndrome, we have criteria, we have some scores, the M score or the H score, but I think a very important point is the trend in terms of ferritin levels, of liver function tests, or of triglyceride level. And if you have a trend to have an increasing level of ferritin, it means that things are not going in the right way. So the change over time during a few days to see if you have a normalization of or an improvement in the biological value is something which is more informative than just a threshold. And finally, for the non-inflammatory, difficult-to-treat patient, I would say here we will apply this comprehensive patient-centered care, and we want to promote this notion of, as physicians, we are not there to prescribe only treatment, but just to organize the care around the patient. And in our department, for example, we have the physiotherapist, the psychologist, the dietitian, just to help the patient to live as normally as possible with their disease and with the treatment. And for this, especially with fatigue is really something which is painful or difficult to live for the patient, but also for the physician, because we don't have any clear treatment for fatigue. And actually, with the physiotherapist, exercise is really a very good treatment just to improve fatigue in these patients. And I will just conclude with this final slide. In this difficult-to-treat patient, we recommended that in the EULAR press working group, but it's really what we are doing in current practice. when there is something wrong with the patient, don't stay, we say to the physician, don't stay by yourself and contact the nearest reference center is something very key. And in Europe, we have the RITA network. In France, we have the FEDOSER network. And actually, we are able to set up online discussion with several rheumatologists or internal medicine specialists and also pediatricians. And we're able to do that within a few days to discuss difficult cases and to find the optimal option. And I think this is what I wanted to share with you today. And if you have any questions.
We have time for 2-3 questions, so.
Michael.
Thank you for sharing your experience with us about this, Dr. Futrell. Our experience is also that fatigue is one of the residual symptoms that's the most difficult to treat. And in my mind, I haven't looked in the data, but in my mind, these patients with the fatigue have mental health difficulties as well. And I don't necessarily see that same analogy in children, but it's pretty clear in the adults. I wonder if you see the same thing in your cohort, that you have depression and anxiety among the patients who have the persistent fatigue.
Yes, but it's not patients who need to be treated by antidepressive agents, for example. It's just they have to face all the problems of everybody's life. And in addition to that, they have the burden of the disease. So this is where you have to help them, and I think that psychologists may be an option. And also they have difficulty to move or to do what they want to do, to study, to work, and it's just to help them to go back into the normal life, the normal society. So this comprehensive care for me is really the best option. And we started that with low back pain patient, and now we are doing the same kind of thing for any kind of rheumatological condition, and actually it's really helpful for the patient. You need the microphone.
So you outline what appears to be a progression of the disease. Is an actual progression of the disease, or patients can skip from one to the other, and can you identify some clinical characteristic and whatever that will tell you that the patient will get to the end of that curve?
Clearly, the predictors that have been identified in children, HLA diabetes 115, so now we do the typing for every patient because it's just to organize the follow-up is an important information. We're using at the time of a diagnosis IL-18, not on a regular basis after that under treatment, but when something is going in the wrong way, we do the test. So these kind of things are really, parameters are really important to identify the patient at risk of hyperinflammatory syndrome. Besides that, it's not very clear. Some people were very, very sick. They were hospitalized in intensive care unit at the very beginning, especially with myocarditis. We have the feeling that they respond very well to IL-1 blockers, and we don't have this the same pattern as what we saw with recurrent macrophage activation syndrome or lung disease patients. So I really think it's how we see the things.
Okay.
Okay. Thank you.
Thank you so much.